Good evening, everyone. Welcome to our webinar on shoulder pain treatment and surgery. My name is Vicky and I'm your host this evening. I'm joined by consultant orthopaedic surgeons, Mr. Nick Bakhti and Mr. Daniel Neen. This presentation will be followed by a question and answer session. So if you'd like to ask a question during or after the presentation, please do so using the Q&A icon, which is at the bottom of your screen. This can be done with or without giving your name. Please note the session is being recorded if you do provide your name. If you'd like to book your consultation, we'll provide contact details at the end of this session. I'll now hand over to our experts and you'll hear from me again shortly.
Thank you very much, Vicky. Good evening, everybody. Welcome to this evening's session talking about shoulder pain, treatment and surgery. Thought what we'd do is start off with some introductions as to what we plan to cover in this session, and then I'll introduce my colleague who's online as well, and then pick out a few conditions just to take you through for some further information as to what to expect. So we hope to cover a little bit more about the shoulder in detail, what makes it tick, how does it move, the important structures that people sometimes know about or have heard about in the background. We'll talk about some common shoulder pain and injury causes, some common treatments that we typically use for them, and what to expect during and after that particular type of treatment. And then we'll take some questions and answers, as Vicky said, afterwards. So without further ado, my name's Daniel Neen. I graduated medical school from University College London in 1999, which seems a very long time ago now. I'm a member of the Royal College of Surgeons of Edinburgh. I've trained in this region as a registrar and have worked for most of the big shoulder bosses in the area. I went and did some further subspecialty training in Exeter and New Zealand and started as a consultant in Dartford and Sidcup back in 2015. Joining Benenden a year later. Currently, I'm a clinical director of Queen Mary's Hospital, and I was lucky enough to have trained in reverse shoulder replacements and was one of the first surgeons to bring it to Dartford and Gravesham Trust. And currently, things seem to be taking off a little bit with reverse shoulders, and I seem to be doing an awful lot of replacements. So the national average currently is about 13 a year. And so far this year, I've done 19 already. And I think that echoes what my colleague has found as well, Mr. Bakhti, doing similar sort of numbers. Mr. Bakhti qualified in 2008 from Guy's, King's and St. Thomas's Medical School. He did his further surgical training in Oxford, but also in the Kent region. He's gained a master's along the way in orthopaedics from the University of Sussex. Instead of New Zealand and Exeter, he did a famous fellowship in Perth, Western Australia, where he learnt some of the tips and tricks he uses these days, and joined me thereafter as a consultant in Dartford. He's currently the trauma lead for Dartford and Gravesham, and is also a visiting senior lecturer for the Canterbury Christchurch University. So, shoulder pain is actually a very common problem. It's second to back pain nationally. It's related a lot to your age as to what it could be causing the pain itself, and varies from trauma or dislocation, repetitive movements, such as if you play particular sports or doing something particularly strenuous in your job. There are various causes such as frozen shoulder or calcific tendonitis that can cause a lot of pain in the shoulder and restrict the ranges of movement thereafter. Obvious trauma can cause fractures of the bones, which then cause long-term pain and dysfunction, but can also rip apart some of the soft tissues that we also have attached to the bones. Notoriously is the rotator cuff, that everybody has heard about, but doesn't necessarily actually know what it entails. We obviously, as we get older, we do wear our joints out, and osteoarthritis comes into play more and more. And we'll talk about these in future slides. I said it was common. It's about 14% of the UK population will have a shoulder problem at some time in their life. And every year, about 1 or 2% present to their GP. Most of these will be to do with the subacromial aspect. So 70% is to do with the rotator cuff itself. Obviously, a lot of this will depend on the anatomy that is causing the pain. And I'll hand over to my colleague now, Mr. Bhakti, to talk about the anatomy for you.
Good evening, everyone. As I was introduced, my name is Nick Bhakti. I'm one of the 4 shoulder surgeons at Benenden, and I'm Mr. Neen's colleague at Dartford as well. So, anatomy of the shoulder joint. So, as you can see on the X-ray, it shows us quite a lot, but there's also quite a lot of overlap. This on the right side of the slide is a normal shoulder X-ray, and we normally use this to diagnose simple things like arthritis, calcific tendinitis. But if it comes to something more complex like the rotator cuff and impingement, then we will require an MRI scan. Next slide, please. The anatomy of the shoulder joint is quite complex. The reason for this is because unlike the hip joint, it's very shallow. The picture on top left shows a golf ball on a golf tee. And the reason why it's so shallow and it's so that the shoulder is supple, it's got lots of freedom of movement so that we can do the things that we want to do. Without the ligaments that's around the shoulder, the muscles that's around the shoulder, it will very simply come out of its joint because it's so shallow. So we rely on the soft tissues, the tendons, the ligaments, and the muscle to work together to keep the shoulder in joint and make it stable. Next slide, please. So this is just a graphical representation of the labrum, which is around the socket of the shoulder. Although it looks very thin and gracile, it's very, very important in keeping the shoulder joint in place. It acts like a information center for the shoulder to know that the shoulder is at the limits of its movement, and it tells the muscle around the shoulder to tense up if it's about to come out. The ligament or the tendon that's crossing the joint that attaches to the socket is the biceps tendon. As you can see, it's very close in proximity to the shoulder joint, and any problems with the biceps tendon can give you quite a lot of pain around the shoulder. The next slide will show you the capsule in blue, and also the other ligaments, the middle, the superior, and the inferior glenohumeral ligament, which only means that it attaches to the ball and socket together. And all this work in tandem to give extra stability to the shoulder joint. The green section in this picture represents the subacromial space. So this is a space that often gives a lot of pain as well. And as Mr. Neen mentioned earlier, it accounts for about 70% of the pain and problems that people present to the GP with. And this is the space that we often inject local anesthetic and steroids into. Next slide, please. This is a picture representing all the rotator cuff muscles around our shoulder. So working from right underneath the skin, you have the deltoid muscle. So the top 2 pictures. That doesn't make part of the rotator cuff muscles, but it's a very important muscle if you do not have your rotator cuff, and we'll discuss this later. The bottom 2 pictures shows the front view and back view of the shoulder with the muscle attachments, and this 4 muscles make up the rotator cuff. Apart from moving the shoulder, they are key in maintaining the stability of the shoulder, and we often refer to them as the dynamic stabilizers of the shoulder. The problem is that they wear out due to age, due to repetitive movement, or other factors, and the supraspinatus muscle, which is at the very top of the shoulder, is the one that's most at risk to damage. Next, please. Next slide, please. So this slide really just shows how everything works together. So if you have a torn tendon or a tendon that's working much harder than the others in the rotator cuff, it can cause the whole shoulder to be slightly off balance in terms of its dynamics. And in the long run, apart from pain, it can cause arthritis, uneven wear of the socket bit or the glenoid bit of the shoulder. Next slide, please. So I'll hand you back to Mr. Neen.
So as we mentioned earlier, there are various forms of treatment that we can perform for these problems. By and large, we will always start off with some physiotherapy, or some physiotherapy would have happened before you come and see us. And the whole point of the physiotherapy side of things is to try and help with that balance that Mr. Bhakti was talking about. Injections of steroid are another tool in our armament that we use to try and firstly diagnose on occasion and sometimes treat as well. So we can use a mixture of local anesthetic, which will numb the pain. And if we inject it into a particular area and your pain dissipates altogether, we know that that is the particular area that is causing your issues. The steroid in it is a very strong anti-inflammatory, and that helps to calm down the issue, almost like stamping out a fire. Unfortunately, the drug doesn't last forever. It does have a finite lifespan that we normally account for about 6 weeks. But again, stamping out that fire can reset the clock, and it can keep the pain away longer term. There are various surgical things that we can do. So arthroscopic just means the keyhole surgery bit. So we can decompress or shave away a bit of bone from the under the acromion, which is the ledge of bone that you can feel on top of your shoulder. And that increases the space and the amount of movement that the tendons underneath can have. We can take away the arthritis in the joint next door to that area. We can try and repair the tendons for you. We can try and repair other tendons around the shoulder as well, depending on which ones have been involved. If you have something called a frozen shoulder, we can release it with the keyhole, or we can even do the bigger open surgery, such as replacing the shoulder surfaces altogether. Starting out with the physiotherapy, we should always seek help with a professional physiotherapist, such as the ones we have here at Benenden. I believe you can self-refer, or we advise you to go and see the physiotherapist if you've not seen one before. It needs a lot of time and a constant sort of input, really, to try and rebalance the joints and to get those muscles working again. And so it's not necessarily an instant fix, unfortunately. As it says, exercises and keeping active certainly can help manage shoulder pain, because it keeps that joint that wants to be so supple, keeping up with the range of movement that it should have. Although obviously balancing that against the pain that you may be experiencing can be quite difficult. If after a few sessions of physiotherapy, the physiotherapist tells you that they really cannot do any more for you, or they don't think that it's being successful, they will then refer on to us for further investigations or potential surgery. I'm going to talk about a few of those common issues, and I'm going to hand you back to Mr. Bhakti at this point in time to talk about the most common.
So that's right. So this is probably the most common presentation that I see in clinic. It's often insidious in onset. It just gradually appears and gets worse. And often this is treated conservatively, i.e. with exercises and possibly an injection. The problem lies where there is a hook of bone that comes around from the front of the acromion. So that is the bone that's at the very top of your shoulder blade, and where your collarbone meets your shoulder blade. Next slide, please. What happens, as you can see on this X-ray, the red bit is the spur, and if you imagine lifting up your arm to reach something out of your side, it can then start abutting or impinging onto the top of the ball bit of your shoulder. I think the next slide shows you, this shows an MRI scan of what could happen if this impingement problem is not treated in the long run. It can cause a tear. So the red arrow on this MRI scan represents a tear of the tendon. And what happens with time is that the impingement can cause an attrition to the rotator cuff and possibly a tear. I think there's a video next. So this is what happens if you, what we call abduct or lift your arm sideways. And if you have a spur on your acromion, it can cause an impingement process at the top of your shoulder. And I thought this was quite a good video to demonstrate this, because sometimes it can be quite difficult to imagine. Now, next slide, please. What we could do. So, as I mentioned earlier, most of the time, I would say more than 50% of the time, this can be treated conservatively with physiotherapy and sometimes subacromial injection. Having a subacromial injection is quite useful, because if it does take the problem away, then it tells us that that's where the problem is. And even if it comes back after 6 weeks or so, we know that physiotherapy and injections has not helped, but an operation is likely to help. And this is only something that we would consider once we've failed conservative treatment of physiotherapy and injections. Now, surgery-wise is keyhole, as demonstrated in this short slide video. What we do is there will be a couple of keyholes, one from the back, one from the side of your shoulder, and possibly one at the front as well. We introduce a camera from the back of the shoulder, and we use a burr. I don't know if you managed to catch that on the video earlier. We could go back and, can we go back one slide and return to this slide, please? So, yes, so we introduce a burr, and what we do with that burr is that we file away that spur that's coming out from the acromion and make a little bit more space for the shoulder to move sideways. And most of the time, if this is done after failure of conservative treatment, patients do get a good response and good recovery following the procedure. Next slide, please. Recovery is a week, 2 weeks maximum in a sling. The longer you keep it in a sling, the stiffer the shoulder will become. So we recommend that the sling is really just there to help you recover from the operation itself. Once it's comfortable, we're happy for you to get things moving. Physiotherapy is again key to get your movement, your strength back. And often patients return to work, depending on whether it's a manual job or admin, between 3 to 6 weeks following the operation. Next slide, please. And I'll pass you on back to Mr. Neem.
Right, frozen shoulder. So this is commonly found in middle age, more often in ladies, unfortunately, sorry. And it's related to diabetes as well. We know that if you have diabetes, you've got a higher rate of having this, and also, unfortunately, a higher rate of getting it in the other shoulder if you've had it in one. It's also known as adhesive capsulitis. And we don't fully understand it, even in this day and age. All we do know is that there are 3 different stages to it. They last roughly 3 to 9 months each, and the whole process can take a couple of years. So initially, it can be quite difficult to diagnose this because pain is the main issue, and it can come out of the blue for no reason whatsoever. It can be a minor trauma, such as a dog pulling on your lead all of a sudden, or it could be a major trauma where you've injured your shoulder for some other reason, and then this comes on as a secondary problem. So pain starts off in this first stage, and slowly, you start getting a stiffer and stiffer shoulder. In the second stage, or the frozen stage, you end up with a very stiff range of movement. The pain eases off by and large, except for when you try and move it beyond what it is able to do. And then you finally go into the thawing stage, or the third stage, where the movements start to come back and everything settles down. But it's a long process. The picture here just shows that the whole process is involved with the capsule, or the skin of the joint, the lining of the joint, and it becomes very inflamed, which is the painful portion. And then it contracts, which is the stiffening up of the actual joint itself. Normally, we try and treat this conservatively as best we can. We've got to be a little bit careful with physiotherapy, particularly in the first stage, because we know that in the first stage it can actually aggravate the situation. But thereafter, it can be a very useful tool to try and help regain some of the range of movement slowly. Pain management obviously is a big to do in this whole process. Surgery is one of the things that we can do. It's in our tool, but normally not until we get into the second stage or thereafter. And the whole point of the treatment is really to try and shift you through the course of this, to try and get you towards the end as quickly as possible. And the operation involves trying to release that thickened, contracted capsule. We do it as a day case, so you literally come in just for the day. It's done under general anesthetic, so you're asleep for it, but we also use a local anesthetic to numb up the arm, so you don't wake up with any pain at all afterwards. Recovery really takes quite a long time, but urgent physiotherapy is one of the key steps, and really we're talking about within the first week of the operation, getting things underway. I was also going to talk about rotator cuff. So the rotator cuff, as we've talked about, are these tendons that attach as a cuff to the edge of the ball for the ball and socket joint. And what we do, if they are torn, depends very much on how this has come about. So there are two types of tear. There are the degenerative ones that have come about through time and wear and tear. And then there are more acute ones, the traumatic ones that have come off because of a sudden force. People complain of pain and an inability to move it, and some people even describe it as a pseudo paralysis, meaning a false paralysis. They feel that their arm is paralyzed, but in actual fact, it's still in working order if we had the torn tendon repaired. The pictures here demonstrate a hole in the tendon at the top, which is the most common tear that we see, really. It's the one that helps to take your arm out to the side. And it shows this sort of chrysantheric type tears, but they can come in all shapes and sizes. And the detachment is a particular problem. If it's fully torn off, unfortunately, the tendon cannot get back down again to where it needs to be. And so surgical intervention is the only way to get that tendon back to where it should be attached. We use a variety of tools to diagnose it. This is a picture of an ultrasound scan. The problem with ultrasound scans is very dependent on the person doing the scans at the time. And although they say they take pictures such as this, they can be quite difficult to interpret if you're not there at the right time. Having said that, it is very good in that it's a dynamic scan. So you move your shoulder around and they can see what's happening when you do the movements, as opposed to an MRI scan, which is very detailed and we can flick through the different images, but it means that you are lying still. And so it's a captured picture at the time that you're lying still rather than dynamic. So relative pros and cons for each. This is a picture of the MRI scan, and it depicts this torn tendon. So at the top of the ball, there is a tendon. I don't know if we can see it here. So this muscle here turns into a tendon that would normally attach to this ledge over here, but you can see that the tendon has pulled off and there's a gap between the two edges. So treatment options are still involved, but potential conservative. There are people walking outside even now with torn tendons that know nothing about it. So we tend to only see and treat the ones that come in complaining of pain and inability to move. If the tendon has partially torn, not fully torn, there is still a chance that it will heal itself, and so no surgery is necessary. And we can just deal with the pain with the injection side of things or physiotherapy. Surgery may be involved later on down the line if it fails to resolve with those initial treatments. If we do go on to repair the tendon, what we tend to do is with keyhole. Some people still open surgery. We know that the outcomes are the same longer term. It's a day case procedure, and we tend to we do a decompression as explained by Mr. Bhakti before to help increase the space for that repaired tendon to move. And the idea is to repair that tendon back down to the bone where it should be, is the idea. But sometimes these tendons, as I said, they come in all shapes and sizes, and they can be torn for quite some time before we get to them, and repair is not achievable. If that is the case, we will talk you through what other options are available to you after the surgery. We tend to keep people in a sling for 6 weeks while that tendon beds down back into the bone. It's not fully healed by that stage, but it's strong enough to support range of movement exercises that a physiotherapist will take you through. If we've done it by keyhole, you tend to have only very small skin incisions around the shoulder. I tend to use about 4 or 5, and they tend to be about 5 millimeters each. We've got a little video here. So this is looking down from on top of the torn tendon. You can see that crescenteric shape with a red bit of bone exposed underneath it. And the idea is to make some holes in the bone through which we stick little anchors. And the anchors are attached to these tapes, which are these blue strands that you can see coming out of them. We then feed those strands through the tendon and then peg them down with 2 further anchors on the outside, and that brings it across the top of the bone. So these strands are holding that tendon in place. They're not as strong as normal tendon, but they hold it in the right place to heal over the ensuing weeks. 3 stages to healing. After the initial stage of the sling and protecting that area, we start getting some movements going, and thereafter we start to strengthen the whole shoulder. People tend to return to driving from 6 weeks, depending on how confident they feel. There's no absolutes with that, but I would suggest at least 6 weeks before you go back. You can't drive, obviously, with a sling. And returning to work, again, does depend on what type of work you do. In general office work, we say wait until you're out of the sling, because commuting can be part of that problem. And manual stuff, you should definitely avoid for a few months while that tendon strengthens up. I'll hand you back to Mr. Bhakti, and he's going to talk about bone and joint wear.
So this is my favorite topic. Shoulder arthritis and shoulder replacement is my favorite operation. So there are 3 x-rays on this slide. The leftmost x-ray represents a relatively normal shoulder joint, and the one in the middle shows arthritis in the shoulder. You can see extra bits of bone at the bottom side of the ball joint, and that represents osteophytes or arthritis. The mouse point is also showing on some loose bodies, often when it breaks off from these osteophytes. The image on the x-ray rightmost shows what happens if you do not have a rotator cuff and it's not repaired. So what happens is the balance in the shoulder is gone, the dynamic of the shoulder is gone, and slowly with time, and we're talking 10, 15 years down the road, the shoulder migrates upwards and there is no space for the shoulder to move sideways. And often range of motion at this point is very limited and very painful. Next slide, please. So when would you have shoulder surgery? So I've seen quite a lot of people who come in with pain to the shoulder, often quite mild, with terrible looking x-rays. So shoulder replacement surgery is only recommended when the shoulder is affecting your ability to carry out the things that you want to do, things like your hobbies, but it can also start impinging on things like putting your clothes on, cleaning, eating, preparing your food. So at that point, if all the other treatments such as physiotherapy, injections has not worked, then we'll start thinking about an operation. The reason for this is because shoulder replacements are quite a big operation. It can't be done keyhole. It has to be done open, and it regularly takes about an hour and a half to do the replacement. Next slide, please. This is just a very quick slide about the principles behind a shoulder replacement. It moves, often you will hear a reverse shoulder replacement being mentioned, and that's because we change where the ball is and where the socket is in the shoulder to make the dynamics or the muscle balance in the shoulder better. Next slide, please. So this is the implant that's used in Benenden. It's the Exactech Equinox shoulder system. It's one of the most common shoulder replacement systems used in the world, with a huge amount of data behind it. This replacement system is very versatile. It can be used for reverse shoulder, anatomic shoulder replacements, or even trauma. And I think the next slide will show you an X-ray to compare the two. Oh, maybe not. I'll tell you about what to expect during shoulder replacement first. So it is not done as a day case, so we expect at least one night stay. During the day of your admission, you'll be visited by the nursing staff, the anesthetist, and we will see you on that day as well to talk you through the operation again. The operation is done under general anesthetic because of the duration of the operation, but our anesthetic colleagues will also give you a nerve block. This involves an injection similar to epidural, but this is in the shoulder. And what it does, it numbs your arm for about a day or a day and a half. This helps you recover from the general anesthetic. And once you've recovered from the general anesthetic, and it allows you to then start taking your painkillers before the pain sets in. As I mentioned earlier, most people stay in for one night. This allows us to monitor you for pain, allows us to take an X-ray after that, and allows us to see whether you can manage with your arm in a sling. The sling is mainly in the first couple of days to allow you to get used to get rid of the nerve block, to get used to your shoulder replacement. And some people can stay up in a sling for about a week or so. Physiotherapy is key. Often patients with shoulder arthritis have severely stiff joints. The replacement helps with the movement, but the stretches and the exercises that are given by our physiotherapy colleagues are key in helping you get the best out of your shoulder replacement. Again, driving, often about 6 weeks onwards, but most patients go back driving at about 2.5 months. It's all about confidence again. Next slide, please. In general, most patients have most of their range of motion back at about 1 month. Active movements, as in movements that you don't need assistance with, at about 3 months. I mentioned before, driving at 6 weeks. Golf at 3 months. Most people go back to the driving range before that. It's the 9-hole and 18 holes that are a bit later. Swimming, depending on the style, breaststroke at 6 weeks, freestyle a bit later at 3 months. And light weights can be done quite early, week 3, week 4, but heavy lifting, so manual labor, a bit later, between 4 and 6 months. I'll pass you back to Mr. Neen about how many is done in this country.
Yeah, so we have been collecting data in this country since, well, for the last 20 years about joint replacements in general. We started collecting data about shoulder replacements from 2012. And I thought it was just an interesting little note. Every year they bring out the new reports from the National Joint Registry, which you'll be asked about, I imagine, if you come into hospital to be part of. We have to ask your consent. And these numbers are collected yearly. And if you look at the number of hips and knees that have been done over the years, you're talking about over 100,000 each. Whereas shoulders, obviously very much the poor cousin, and we're down at the sort of 6,000-7,000 mark. You see in 2020, all of them took a bit of a dip, and that's because of COVID and the lack of elective surgery that we were performing at that stage in different parts of the year. Ankles and elbows obviously are lagging far behind. They do have joint replacements, but the indications are limited, and the technology is still improving. Shoulders are one of the fastest growing joint replacements currently. As part of the last report, again, just comparing when they first started bringing out the numbers, 35% of them were only these hemiarthroplasties. That means we were just replacing the ball and that was it. They've dropped off to about 5% now, because we've realized that the outcomes are not as good as we wanted them to be. And you can see that the reverse polarity shoulder replacements have much improved in numbers. So we're now about 2/3. Obviously, technology is coming on, and Mr. Bhakti uses this a lot. He's going to talk to you about what we do with the Exactech kit.
So this is my special interest. So I like the use of technology in surgery, not only to help us surgeons, but also to help improve the outcomes following surgery for our patients. So this system that we use from Exactech allows us to marry your CT scan that we get for you before your operation, and it allows us to use it in real time using a computer navigation so that we can plan your operation before and reproduce that during the operation. So the next slide will just show you the system. So this is in real time. So it allows us to accurately plan where we're going to put the implants. And during the operation, we will match your CT scan and the plan, and it will allow us to exactly place the implant for your shoulder replacement according to plan. So the hope for this is that it gives you a better outcome, range of motion, but it also is very useful for patients with very severe arthritis, and there's not much bone in the shoulder or the socket joint, and it allows us to maximize the hold of the screws and the implants that we put in your shoulder to reduce the risk of failure. Next slide. And I think that brings us to the end of our talk here.
Thank you very much, Mr. Bhakti and Mr. Neen. We'll now take some questions. So please do leave your questions in the Q&A icon on the screen. So the first one we've got is, if I had a shoulder replacement, would I ever be able to get back to my job, which involves a lot of heavy lifting?
Mr. Bhakti, do you want to?
So I'll take this one. So yes, the answer is the aim for shoulder replacement is to get back to what you need to do. I think it very much depends on what kind of heavy lifting. So, if it's 50, 60 kilo stuff, then we have to be slightly sensible and protracted in terms of our outcome. But most of my patients, they are so amazed by the improvement in terms of function and mainly pain following shoulder replacement that a few of them have said that it's restored their independence and their life.
Okay, thank you very much. Another question, does a rotator cuff tear get worse if treatment is delayed or put off? I'm wary of having surgery.
So the answer to that one is a bit tricky because it depends on the type of rotator cuff tear you've got. If it's a partial thickness tear, then potentially putting off surgery is not necessarily a bad idea at all. It gives it a chance to heal itself. And so we would employ all those injections, physiotherapy, and time to see if that doesn't do that on its own. If it's a full thickness tear, unfortunately, there is a good chance that this will get worse with time. We know that even the asymptomatic ones, unfortunately, do become symptomatic, particularly if you continue to do activities that potentially rip it further. And unfortunately, we know that with the full thickness ones, because the muscle sometimes isn't able to function as it normally would do, it wastes away. And it can get to the point that the muscle is wasted away so much that we are unable to fix the tendon altogether. So it's a bit of a delicate balancing act, and it's a good idea to have an idea where you are on that tightrope. And I'm sure that a surgeon, a shoulder surgeon, will be able to help you answer that one.
Okay, thanks, Mr. Neen. The next question is, after a rotator cuff tear is treated, could I go to the gym or lift weights in the future when I'm fully recovered?
Do you want me to take this one, Mr. Neen?
Surely.
So yes, we expect you to be able to return to the gym and lift weights. Often there is a spur at the top that can be causing an attrition to the tendon. So when we do a repair, we'll take away the spur, repair the tendon, and after a period of rehabilitation, we expect you to return to normal activities.
Okay, thank you. Hope that was helpful. The next question, I recently started hormone treatment for prostate cancer and then developed a shoulder problem, weakness. Is this likely to be linked to the hormone implants?
Oh, that's a difficult question. The honest answer, I don't know. There are papers out there recently talking about hormones and their relationship to shoulder pain per se, and they are finding a link. Testosterone was one that I've recently looked into, so I know that there is a link, most definitely, but it's kind of something we have to rule out. So if we want to know that there isn't any physical damage, that there isn't anything physical that we can actually repair or adjust for you, before we say, yep, it's down to the hormone replacement side of things. So again, it's one of those questions where I think a bit more information would be useful. It's not out of the complete, we know the fact that we definitely can't say it's to do with that, but I think we just need a little bit more information.
Okay, thank you. Next question is from Sarah. Sarah asks, my physiotherapist told me that I have a frozen shoulder. My movement's improving, but the pain is down the front of my arm to my elbow. I'm not sure that diagnosis is correct.
Hi, Sarah. Thanks for your question. So often it doesn't have to be an ice or a single problem that's causing a shoulder issue. You may have had a frozen shoulder, and it's good to hear that your movement's improved, but sometimes there could be concurrence or other issues that are going on in your shoulder, like inflammation of the tendons. And from what you say, it could even be involving your biceps. So they don't often happen in isolation. They all can occur together. And even when the frozen shoulder settles, you may have ongoing issues. So if you're worried, come and see one of us and we can have a look at it.
Right, that's great advice, I think. Hope that's helpful, Sarah. Next question is from William. William asks, what type of shoulder pain would you expect with the various conditions you described? I have shoulder pain which extends down to my fingers. Would this indicate some of the issues you have described?
Absolutely, yeah. So surprisingly, people do get referred pain. And the pain can literally go down to the fingers with shoulders. It's unusual, but people regularly describe pain going down the outside of their arm, halfway down their arm. And this is a classic referred pain that it's all to do with the nerves in the shoulder and where they innervate. And so although the problem is at the top of your shoulder, it actually feels like it's coming halfway down your arm on the outside. It doesn't just stay there, though. Sometimes people do talk about it emanating down to the elbow, even down to the wrist, and on rare occasions into the fingers. If it is into your fingers, we'd be more likely to think that it is related to nerves potentially, and there are various causes of nerve issues related to the shoulder or even further up towards the neck that can emanate down towards the hand. And so diagnosis-wise, we'd have to do a proper history and examination. Frozen shoulder is a classic one for this jerk type pain. So somebody would suddenly try and do something such as catch something that's falling off a table, and they would describe this intense burning sensation in their shoulder that lasts for about 30 seconds to a minute before dying off. Impingement, it typically is a pain on the outside of the arm with movements going out, with your elbow going out sideways or reaching up above you.
Okay, thank you, Mr. Neen. Next question is from Ben, and Ben asks, what are your thoughts on hydrodistension in the treatment of frozen shoulder?
I'm a great proponent of this, and I think Mr. Neen is as well.
Yeah, absolutely.
It is one that is performed by our radiology colleagues, so our X-ray colleagues. They do it under X-ray or ultrasound guided, and in most circumstances, and maybe in 2/3 of cases, it helps significantly with not just pain, but also movement.
Okay, thank you. Thanks, Ben. Next is from Gavin. I've had an X-ray and been told I have arthritis. Do I need other scans to establish 100% that it is only arthritis issues I have and not something else, such as a tear?
So Gavin, sorry to hear about the arthritis. I would suggest that an X-ray is adequate to diagnose the arthritis itself. We can see typical changes on an X-ray for arthritis. The reason for further scans will really be to do with planning any further treatment. So as we've alluded to, there are two options. If you were going down shoulder replacement, for example, you can either have the anatomic if all your tendons are attached, or a reverse shoulder if there is any damage to the tendons. So first of all, an ultrasound scan or an MRI scan will help tell us that for sure, so there's no guesswork involved. And then to plan the actual replacement itself, a CT scan would be used. And a CT scan is basically like a glorified 3D X-ray, and it gives us far more detailed information about the bone structure, and we can plan the sizes of and positions of all these implants that we potentially use. So X-ray is good, but then we use other things to give us further details.
Lovely, thank you. Anonymous asks, do you have any statistics on the success rate for shoulder replacements?
So shoulder replacements have been around for quite some time, and as Mr. Neen mentioned earlier, we've been keeping data on them since 2013. So yes, they do well for the right problem. So for arthritis, for patients with chronic rotator cuff problems, with movement issues that is not repairable, then they do really well. They predictably manage, they reduce your pain very well. Movement, often 90% improvement in movement. But of course, no operations without risks. And I think it's all quite individual. So if you do think that you have shoulder arthritis that requires shoulder replacement, I think it's best that we examine you, investigate how bad the problem is, and we can discuss the pros and cons, or the risks and benefits of a shoulder replacement.
I think in terms of the reverse shoulder in particular, the results are extremely good, 15 years. So it's a relatively new technology, reverse shoulders, but we're on our 4th or 5th generation of changes now. And the longer term follow-up is starting to come through. And so 15 years plus follow-up has shown extremely good results of over 90% success and satisfaction. And for that reason, I think the numbers of reverse shoulders being used now is growing and growing, because we have that faith that it does a good job in the longer term.
Okay, lovely, thank you both very much. And next question is from Francis, and they ask, I was diagnosed with severe shoulder osteoarthritis last year. For the last 4 months, I've had physiotherapy. I'm still in pain with reduced movement. How do I know if I need a shoulder replacement?
Mr. Bhakti, do you want to?
I think, yeah, I don't mind taking this one. Francis, I think the best way forward is to get some form of imaging. So most simply, it's an X-ray that will confirm if you have arthritis or not. And based on that, if you do have arthritis, we can then discuss based on how much limitation, movement and pain you have, whether you are a good candidate for a shoulder replacement.
Okay, thanks, Mr. Bhakti. We've got time for a couple more questions. So Robert asks, I've been diagnosed with joint effusion around the biceps tendon and capsulitis. I've had 4 steroid injections over 30 years. Massage helps, but should I think about physio before asking about surgery to deal with discomfort rather than pain?
I think that physiotherapy would be a very good starting block. I think you've obviously had quite a number of steroid injections. If I see somebody with sort of this diagnosis, I would tend to suggest 1 or 2 injections just to help with the diagnosis and to see if that calms the situation. But if it keeps coming back, then I think that I would talk about a more permanent solution. And there are things that we can do for the biceps tendon specifically to stop it having this problem. having said that, if you've not had any physiotherapy at all, it could be worth trying, just to see if they can get the muscle balances and to make sure that if you're doing something specifically that's agitating it, is there a better way of doing it?
Okay, hope that was helpful for you. Next question is from Vivian, and she says that her shoulder pain came on quite rapidly about 10 weeks ago. She gave it about 6 weeks before going to the doctors, who referred her to physio, and she has her first appointment through Benenden tomorrow. But the pain is getting worse instead of better. She's been using ice and recently heat as well, but that's causing pain even when sleeping. She asks, do you think I should insist on a CT or MRI to find out what's happening? I'm concerned that waiting could result in a more serious issue. And she also adds, she's a horse rider, very active, currently very limited in what she can do, and worried that the pain will be life limited if she doesn't get it sorted.
Hi, Vivian. I think you giving it some time to see if it settled was a very good idea. The fact that it hasn't settled means that you probably need some help. Surprisingly, physiotherapy and my physiotherapy colleagues, they are very knowledgeable. They might be able to give you a better idea of what the problem is. And with the exercises, we've seen amazing results. But the fact that you had no problems with your shoulder 10 weeks ago, if physiotherapy and conservative treatment doesn't help, then I feel that between CT and MRI scan, an MRI scan will give you a better idea if it's appropriate. A CT scan, like what Mr. Neen mentioned earlier, is a glorified 3D X-rays. And often MRI scans give us a better idea of what's happening around the shoulder and the structures around it.
Yeah, that's helpful for you, Vivian. Yeah, best of luck with your treatment. And the final question is from Jasper, and he asks, could you please tell us what the future of robotically assisted shoulder replacements are shaping up to be? What are the upsides, downsides? Can they lead to muscle waste, etc.? Will they enhance strength?
Wow, okay. So, I mean, Mr. Bhakti normally deals with all these technological questions, but my take on robotically assisted shoulder replacements, they are definitely coming. It's not a question of if, it's when. They have recently started knees and hips around this region. And I know we have a robot here in Benenden now to help with the knees. And in essence, what it appears to be doing is helping guide the surgeon during the operation itself as to where to make the safest cut and how to direct the bits that they can't see within the bone. With our GPS system that we use with Exactech, it does pretty much the same sort of thing. It's guiding your hand as to where you want to be drilling, and then putting the screws. It can tell us how deep the drill is going. And the whole idea of it is really to increase the accuracy of where we put these implants, with the vision that longer term, this will give you the best optimum outcome. The evidence for it is not 100% just yet in terms of, is that 1 or 2 degrees accuracy actually equating to a better clinical outcome? And shoulders are lagging behind. I understand that in America, they are now starting to do these first shoulder replacement, robotically assisted shoulder replacements. So it'll be some time before it comes over here. But I think, yeah, onwards and upwards, I'm all for it. The only problem I can see is that if people become so reliant on robots during an operation, one suddenly stops working, what do you do?
So I echo Mr. Neen's comments. Actually, I think last week, the first robotic shoulder replacement was done in America, the first one. And like Mr. Neen said, across the pond, we are a few years behind. So my opinion about all of this, just like the GPS system, it improves accuracy, but whether it changes clinical outcomes, we don't know. But where I think it's valuable is in complex or severe shoulder arthritis, where there's very little bone to play with, or there's very little leeway where we can place our implants. That's where the benefit of the robotic or a navigated shoulder replacement is. And we're seeing more and more of this, I think. Do you agree, Mr. Neem?
I do, yeah, absolutely.
Lovely, thank you both for that. It's a good one to end on there. Thank you for everyone for your questions. And just let you know that as a thank you for joining this session, we're going to be offering 50% off the value of your initial consultation, a call back from your dedicated private patient advisor, an email tomorrow with the recording of the webinar, treatment information and loyalty reward points, which you'll get for attending this webinar, and also updates on news and future events as well. We'd be really grateful if you could complete the survey at the end of this session to help us shape future events as well. If you'd like to discuss or book your consultation, our private patient team can take your call until 8:30 this evening or between 8 AM and 6 PM, Monday to Friday, using the number on the screen. Our next webinar is on treatment for hip osteoarthritis, which you can sign up to on our website. So on behalf of Mr. Neen and Mr. Bhakti and our expert team at Benenden Hospital, I'd like to say thank you very much for joining us tonight, and we hope to hear from you very soon. Thank you and goodbye.
Good night.